Hello students, welcome to this session. Let's study Enterobacteriaceae. So in that we will see E. coli, Klebsiella, Proteus, Yersinia, Salmonella and Shigella. So Enterobacteriaceae family characters are gram-negative bacilli, aerobes and facultative anaerobes, non-fastidious. Ferment glucose to produce acid with or without gas. Reduce nitrate to nitrite. Catalase positive, oxidase negative. Motile with peritrichous flagella or non-motile. Mostly commensals in human intestine, coliform bacilli. So classification, lactose fermenters, LF, all are coliform bacilli, ferment lactose producing acid. On Mekongki agar produce pink color colonies. And example is Escherichia, Klebsiella, Citrobacter. Non-lactose fermenters do not ferment lactose, produce pale or colorless colonies on Mekongki agar. Salmonella, Shigella, Proteus, Morganella, Providentia, Yersinia. Let's study E. coli, Escherichia coli. So virulence factors, most common aerobe harbored in gut of humans and animals. Surface antigen, somatic O, most important virulence factor, endotoxic activity, protects from phagocytosis and bactericidal effect of complement. Second, flagellar antigen, capsular antigen K and fimbrial antigen. Toxins, hemolysin, virulent strains of E. coli, especially pyelonephritis strain. Cytotoxic necrotizing factor 1 and secreted autotransporter toxin. Cytotoxic to bladder and kidney cells. Enterotoxin produced by diarrhenic strains of E. coli, heat labile toxin, heat stable toxin, and virocytotoxin. Toxins LT and ST, heat labile and heat stable. So heat labile toxin produced by enterotoxigenic E. coli, plasmid podate, resembles cholera toxin. Mechanism of action, subunit B binds to GM1 ganglioside receptors on intestinal epithelium. A fragment is internalized and cleaved into A1A2 peptides. Fragment A2 help in tethering A and B subunits together. Fragment A1, active fragment, causes ADP ribosylation of G protein, upregulates activity of adenylate cyclase, intracellular accumulation of CAMP, increase outflow of water and electrolytes into gut lumen, diarrhea. Detection of LT, toxin detection, latex agglutination, ELISA. Molecular methods, PCR detecting gene coding for LT. Heat stable toxin produced by enterotoxigenic E. coli, plasmid coated, ST of two types, ST1, ST2. ST1 mechanism binds to guanylate cyclase C, increased production of cGMP, and fluid accumulation in gut lumen, diarrhea. ST2 causes fluid accumulation by unknown mechanism. Detection of ST same as LT. Clinical manifestations, one of most common pathogen encountered clinically, urinary tract infection, uropathogenic E. coli. Diarrhea, 6 types of diarrhogenic E. coli, enteropathogenic EPEC, enterotoxigenic E. coli, ETEC, enteroinvasive EIEC, enterohemorrhagic EHEC, enteroaggregative EAEC, diffusely adherent E. coli, DAEC. Other infections, abdominal infections, commonest cause of primary and secondary bacterial peritonitis, visceral abscesses, hepatic abscess, pneumonia in hospitalized patient, VAB, meningitis, especially neonatal, wound and soft tissue infection, cellulitis and infection of wounds, osteomyelitis, endovascular infection, and bacteremia. Laboratory diagnosis, specimen collected, pus, exudate and wound in cellulitis and pyogenic wound, urine in UTI, stool in diarrhea, CSF meningitis, peritoneal exudate peritonitis, sputum pneumonia, tracheal aspirate, ventilator associated pneumonia, blood bacteremia. Direct microscopic examination stained by gram staining. Smear shows gram-negative bacilli. Culture aerobe and facultative anaerobe, non-fastidious. Blood agar colonies are big, circular, gray, moist, occasionally beta hemolytic. Mekongki agar pink due to lactose fermentation. Liquid medium, uniform turbidity. Culture smear and motility, gram-negative bacilli. Hanging drop method, motile bacilli. Biochemical test, catalase positive, oxidase negative. IQ test, indole positive, citrate urease negative, triple sugar ion shows A by A, yellow, yellow, gas present, H2S absent. methyl red positive, VP negative. To summarize, E. coli morphology gram-negative rods, single peritracheate flagella, motile, classification enteropathogenic, enterotoxigenic, enteroinvasive, enterohemorrhagic, enteroaggregative, diffusely adherent E. coli. Pathogenicity, urinary tract infection, diarrhea, pyogenic infection, wound infection, peritonitis, meningitis, septicemia. Laboratory diagnosis, specimen collection according to the manifestation like urine, pus, stool, sputum, etc. Direct microscopy gram-negative bacilli on gram staining, culture characters, blood agar, beta hemolytic gray circular colonies, Mekongki agar pink due to lactose fermentation, moist colonies, biochemical reaction, indol positive, MR positive, PP citrate urease negative, motile TSI ABA A with gas and no H2S. Let's study Klebsiella. Klebsiella found as commensal in human intestine and as saprophytes in soil. Genus Klebsiella has two species, Klebsiella pneumoniae and Klebsiella oxytoca. Lactose fermenters, non-motile and capsulated. Pathogenesis Klebsiella pneumoniae, subspecies pneumoniae. The most pathogenic, the severe lobar pneumonia, destructive with production of thick mucoid brick red sputum. Second, urinary tract infection, meningitis in neonates, septicemia, and pyogenic infections such as abscesses and wound infection. Colonize the oropharynx of hospitalized patients. Common cause of nosocomial infection. Most hospital strains are multi-drug resistant. Klebsiella ozini subspecies, tropic rhinitis ozina, foul-smelling nasal discharge, biochemically inactive. Klebsiella pneumoniae subspecies rhinoscleroma, chronic granulomatous hypertrophy of the nose, Southern Europe, India and Central America, biochemically inactive. Laboratory diagnosis, specimen sputum, endotracheal aspirate, blood exudate, direct microscopy, gram staining, short, plumb, straight capsulated gram-negative rods, culture Mekongki agar, large dome-shaped mucoid tube capsule, sticky pink color lactose fermenting colonies, biochemical indol test negative, citrate urease positive, triple sugar ion A by A, that is yellow, gas present, H2S absent, methyl red negative, VP positive. Klebsiella oxytoca is biochemically similar to pneumonia but differs from by indol positive. And then fifth is the AST, antibiotic sensitivity test. To summarize, Klebsiella, morphology gram-negative bacilli non-motile. Classification Klebsiella pneumoniae and oxytoca. Klebsiella pneumoniae of three species, that is Klebsiella pneumoniae, ozini and rhinoscleromatis. Pathogenicity of Klebsiella pneumoniae, pneumonia, nosocomial infection, ventilated associated pneumonia, urinary tract infection, diarrhea, pyrogenic infection, septicemia, meningitis. Lab diagnosis, specimen sputum, endotracheal aspirate, gram staining, short, plumb, straight capsulated gram-negative rod. Culture Mekongki agar, large dome-shaped mucoid, pink color because of the lactose fermentation colonies. Biochemical test, indol MR negative, VP citrate urease positive, TSI A by A, AST. Hello students, let's study protein. So protein of three genera, Proteus, Morganella, Providentia. PPA positivity is the unique character. They produce enzyme phenylalanine deaminase which converts phenylalanine to phenylpyruvic acid. All are motile and lactose non-fermenter. Colony has fishy pungent odor. They are commensal in human intestine. Pathogenicity, urinary tract infection, pyelonephritis, nosocomial infection, pyogenic, wound infection, diarrhea. Pathogenesis, Proteus mirabilis and vulgaris commonly encountered species. Saprophytes widely distributed in nature, decomposing animal matter, sewage and soil. Commensal, moist areas of skin, intestine of humans and animals. Infections produced opportunistic pathogens, urinary wound and soft tissue infections and septicemia. Nosocomial outbreaks. White stones in bladder produce urease, breaks down urea to form ammonia that damages renal epithelium and makes the urine alkaline. Deposition of phosphate, renal calculus. Proteus as the basis of Will-Felix reaction. Somatic antigen non-motile Proteus strains OX2, OX19 from vulgaris and OXK from mirabilis cross-react with antigen to form rickettsia species. To some rickettsia species, protease antigens are used to detect head profile antibodies in serum of patients suffering from rickettsial infections. Laboratory diagnosis: specimen according to type of infection like urine, stool, swab, pus, direct microscopy, gram positive, gram negative, pleomorphic bacilli, pleomorphism. Proteus species are gram negative cocobacilli, occasionally appear bacillary and in filamentous forms. They produce characteristic putrid, fishy or seminal odor in culture. Swarming: ability to spread on the surface of solid media. Swarming pattern: continuous, discontinuous swarming. Common problems in laboratory: proteus tends to swarm and overgrow other bacterial colonies in samples with multiple types of bacteria. Both Mirabilis and P. varialis are urease positive, citrate variable, TSI, alkaline acid gas present, H2S present, MR positive but VP negative. For species differentiation, indole test positive in P. vulgaris and negative in P. mirabilis. Ornithine decarboxylation negative in P. vulgaris and positive in P. mirabilis. Proteus gram-negative rods swarming motility. Proteus mirabilis and Proteus vulgaris. Morganella morgagni. Providentia, P. Ridgeri, Stewarti, alcalifaciens. So these are the species. Pathogenicity: urinary tract infection, pyelonephritis, nosocomial infection, pyogenic wound infection, diarrhea. Laboratory diagnosis: specimen, urine, and according to the specimen manifestation. Direct microscopy: gram-negative bacilli, pleomorphism. They are gram-negative cocobacilli. Odor: fishy or putrid or seminal odor in culture. On blood agar swarming, ability to spread on solid media. By chemical: indole citrate urease positive, PSI, alkaline acid, that is K by A, gas variably present, H2S present. Now students, let's study Ursini. So Ursini has genus Ursinia, three species: Yersinia pestis, rodent-borne zoonotic disease plague; Yersinia pseudotuberculosis; and third is Yersinia enterocolitica, that is causes yersinosis, a self-limiting gastrointestinal illness. Yersinia pestis, 1984. Yersinia pestis isolated for first time by Alexander Yersin in Hong Kong. Agent is zoonotic, transmitted from rodents. Reservoir: wild rodents, field mice. Source of infection: infected wild rodents, rat fleas, and cases of pneumonic plague. Vector: rat flea, Xenosylla chuopis, most efficient. Plague cycle: two natural cycles, domestic and wild or sylvatic cycle. So domestic cycle between humans, rat fleas, and rodents. Wild or sylvatic cycle occurs in nature among wild rodents independent of human beings. Mode of transmission: bite of infected rat flea, most common. Direct contact with tissues of infected animal, that is rodents. Droplet inhalation, man to man, pneumonic plague. Blocked flea: bacilli multiply enormously in the gut of flea and may block the proventriculus. While making effort to suck, it regurgitates the blood mixed bacteria into bite and transmission of infection. Bite of infected human flea: contamination of bite wound with feces of infected fleas. Partially blocked flea is more dangerous than completely blocked flea. Extrinsic incubation period: 2 weeks for Xenosylla chuopis. Chuopis index is the average number of Xenosylla chuopis per rat is most significant flea index. If it is more than one, outbreak is likely. Ursini, common to all Yersinia. Virulence factors: antigens, lipopolysaccharide, pigmentation, low calcium response plasmid, and siderophore. Y pestis specific: fraction 1, F1 antigen, phospholipase D, murine toxin, and surface proteases. Human plague clinical types: 3, bubonic, pneumonic, and septicemic. So first, bubonic plague, most common type, transmitted by bite of infected rat flea. Bacilli pass through local lymphatics, regional lymph nodes, and multiply. Incubation period: 2 to 7 days. Sudden onset fever, malaise, headache, and painful lymphadenitis. Buboes are regional lymph nodes, tender swellings called buboes, common site inguinal, other sites scleral, axillary, cervical, submaxillary. Cannot spread from person to person. Without treatment, dissemination occurs, leading to pneumonia, secondary, and meningitis. Second is the pneumonic plague, spread inhalation of bacilli in droplets expelled from another person or animal with plague pneumonia. Incubation period 1 to 3 days. Manifestation sudden onset fever, headache, respiratory symptoms, pain, less than 1%, but highly infectious and highly fatal agent of bioterrorism. Third, septicemic plague. Secondary septicemic plague is more common than primary from spread of bubonic or pneumonic plague. Incubation period 2 to 7 days. Hemorrhages in the skin and mucosa, gangrene of affected site, that is black death. Laboratory diagnosis: specimen bubonic plague, pus or fluid aspirated from buboes, pneumonic plague, sputum and blood, septicemic plague, blood and splenic aspirate postmortem. Transport medium, carry-Blair medium. Gram staining, gram-negative oval cocobacilli surrounded by capsule. Bipolar staining and pleomorphism in older culture, also called as septipine appearance, non-motile and capsulated. Wesson stain or methylene blue stain, bipolar or septipine appearance. Culture: Y pest is aerobic and facultatively anaerobic. uh, Non-fastidious, blood agar, non-hemolytic, dark brown pigmented colonies, absorption of hemin. Meconic agar, lactose non-fermenting. Nutrient broth, granular turbidity, surface pellicles, neutral broth with oil or ghee floated on top, satellite-like growth. Arsinia specific CIN agar, Cipsulodin, Irgazan, and Novobicin. Selective medium useful for culture of specimens containing normal flora, that is sputum. Culture smear and motility: gram stain, pleomorphic bacillary, filamentous, and giant forms. Y paste is non-motile at 25 and 37 degree. Biochemicals: catalase positive, oxidase negative, indole urea citrate negative, MR positive, but VP negative. Biotyping is done based on glycerol fermentation and nitrate reduction. Other test: F1 antigen detection from buboaspirate or sputum by direct immunofluorescence test, ELISA immunochromatographic test. Antibodies to F1 antigen detection by ELISA, passive agglutination, complement fixation, limited diagnostic value as they appear late, useful epidemiological marker. Molecular methods: PCR, gene coding, F1 antigen, ST gene, and the plasminogen activator gene. Animal inoculation, guinea pigs or white rats. Treatment: gentamicin drug of choice. Other drugs: streptomycin for 10 days, levofloxacin for treatment and post-exposure prophylaxis, doxycycline and chloramphenicol. Beta-lactams and macrolides are generally not recommended as the response is poor. Prevention: control of cases by early diagnosis, isolation and treatment of cases, control of fleas by use of effective insecticides, DDT-BSC, control of rodents, chemoprophylaxis, contact of pneumonic plague, doxycycline 100 mg BID, tetracycline 500 mg QID. Vaccine only for prevention of anticipated outbreak and not for general use. Formalin killed vaccine, showcase modification of original half-kin vaccine. Subcutaneous, 2 doses 4 weeks apart, booster after 6 months. Protection short lasting less than 6 months, not protective against pneumonic plague and has considerable side effects. Second live attenuated vaccine based on strain EV76, still used in countries of the former Soviet Union, has significant side effects. Subunit recombinant F1 or F1 vaccine under trial. Yersinia pestis, mode of transmission: bite of infected rat, flea. Most common, direct contact with tissues of infected animal, that is rodents, droplet inhalation, man-to-man, pneumonic plague. Pathogenicity: plague, clinical types 3. First, bubonic plague, most common, sudden onset fever, malaise, headache, painful lymphadenitis, buboes. Regional lymph nodes, dense tender swellings called buboes. Common site inguinal, other axillary, cervical, submaxillary, cannot spread from person to person without treatment. Dissemination occurs leading to complication of pneumonia and meningitis. Pneumonic plague spread inhalation of bacilli in droplets expelled from another person or animal with plague pneumonia. Manifestation, sudden onset fever, headache, respiratory symptoms, and highly infectious, fatal. Agent of bioterrorism. Septicemic plague, secondary septicemia plague is more common than primary. Spread of bubonic or pneumonic plague. Hemorrhages in the skin and mucosa, gangrene of affected site, black death. Lab diagnosis specimen, bubonic plague pus or fluid aspirated from mucus, pneumonic plague, sputum blood, septicemic plague, blood and splenic aspirate. Transport medium, carrier medium. Gram staining, gram negative oval bacilli surrounded by capsule. Methylene blue stain, bipolar safety pin appearance. Culture, Y-pestis blood agar non-hemolytic dark brown pigmented colonies because of the aspiration of the absorption of hemine. Mekonki agar lactose non-fermenting colonies. Hello students, let's study Salmonella. So clinical classification, oldest is the friendly one. So first is typhoidal salmonella, which includes serotypes like S. typhi and S. paratyphi, restricted to human host, which causes enteric fever, that is typhoid and paratyphoid fever. Second is the non-typhoidal salmonella, all NTS. They colonize intestine of animals and also infect humans, causes gastroenteritis and septicemia. Antigenic structure, three important antigens on their cell wall: somatic antigen O, flagellar antigen H, and surface envelope antigen VI found in some species. So VI antigen, surface polysaccharide envelope or capsular antigen covering the O antigen, named with the belief that VI antigen is related to virulence, expressed in only few serotypes: S. typhi, S. paratyphi, S. dublin, and some strains of Citrobacter frundi. Renders the bacilli inagglutinable with O antiserum, agglutinable after boiling or heating at 100 degrees Celsius for 1 hour, which removes VI antigen. VI antigen is poorly immunogenic and antibody titers are low, not helpful in diagnosis of cases. Complete absence of VI antibody, poor prognosis. Disappears early in convalescence. If persist, then it is called carrier state. Fast typing or F typing using VI specific bacteriophages. VI antigens used for vaccination. The features of O and H antigen. O antigen, somatic antigen. H is flagellar antigen made up of proteins flagellin. O is part of cell wall lipopolysaccharide. H confers motility to the bacteria. O is heat stable, alcohol stable. H heat labile, alcohol labile. O formaldehyde labile. H formaldehyde stable. O in Vidal test, O antigen of S. typhi is used. In Vidal, H antigen of S. typhi, S. paratyphi, and A and B are used. O antigen is less immunogenic, H is more immunogenic. O antibody appears early, disappears early, indicates recent infection. H antibody appears late, disappears late, indicates convalescent stage. When O antigen reacts with O antibody, forms compact granular chalky clumps. Agglutination takes place slowly, optimum temperature 55 degrees Celsius. When H antigen reacts with H antibody, forms large, loose, fluffy clumps. Agglutination takes place rapidly, optimum temperature 37. Serogrouping is based on O antigen. Serogroups are differentiated into serotypes based on H antigen. O antigen, also called Boyne antigen, extracted from bacterial cell by treatment with trichloroacetic acid, first shown by Bovin. Flagellar antigens exist in two alternative phases, phase 1 and phase 2. Most of them are biphasic except monophasic, S. typhi. Typhoidal salmonella, S. typhi, S. paratyphi, ABC, which cause enteric fever. Pathogenesis, transmission fecal-oral, infective dose minimum 10 raised to 3 to 10 raised to 6 bacilli. Risk factors which promote transmission: Conditions that decrease stomach acidity, less than 1 year age, antacid ingestion, achlorohydria or prior Helicobacter pylori infection. Intestinal integrity, inflammatory bowel disease, prior GI surgery or suppression of the intestinal flora by antibiotics. Entry through epithelial cells, M cells lining the intestine. Bacteria-mediated endocytosis mediated by type 3 secretion system. Entry into macrophages, salmonella containing vacuoles cross epithelial layer to reach submucosa, phagocytosed by macrophages. Survival inside macrophages induce certain alterations on its surface, which causes insusceptible to lysosomal enzymes. Primary bacteremia from inside macrophages spread via lymphatics to enter the bloodstream. Transient primary bacteremia spread disseminate throughout the reticuloendothelial tissues, liver, spleens, lymph nodes, and bone marrow. Further multiplication. Secondary bacteremia occurs from the sedated organs and which causes the clinical manifestations. Clinical manifestations, incubation period 10 to 14 days, fever, left step ladder pattern type of remnant fever, other symptoms headache, chills, cough, sweating, myalgia, and arthralgia. Rash called rose spots, faint salmon colored, blanching, maculopapular rash, trunk and chest 30%. Early intestinal manifestations, abdominal pain, nausea, vomiting, anorexia. Important signs hepatosplenomegaly, epistaxis, and relative bradycardia. Complications, GI bleeding, intestinal perforation in third and fourth week of illness. Neurologic manifestations, meningitis, cerebellar ataxia, neuropsychiatric symptoms, muttering, delirium or coma and vigil, paranoid psychosis, hysteria, delirium, and aggressive behavior. Lab diagnosis of enteric fever. So first is the sample collection. So according to duration of illness, the specimen and test done. So first week, culture of blood, bone marrow aspirate, duodenal aspirate. Second and third week, serum for antibody detection by Vidal test for antigen detection. And stool and urine culture. Fourth week, stool and urine culture. Carrier, stool and urine culture. Serum for detection of antibodies to VI antigen. Sewage culture, indirect way. Culture. So first blood culture sensitivity 90% in the first week. Clot culture, blood is centrifuged, serum for Vidal test and clot for culture. Culture medium conventional brain heart infusion broth, Castaneda's biphasic medium, that is by BHI agar slope and BHI broth. Automated blood culture systems like Bactec and Bacti alert. Sodium ethanol sulfonate SP is used as an anticoagulant, counteracts bactericidal action of the blood. Incubation 37 degrees Celsius up to 1 week. Repeat subculture, monophasic BHI medium, periodical subculture onto blood agar and Mekongki agar. Biphasic medium, BHI is preferred over monophasic subcultures in the same bottle. Automated blood culture system, monitor growth continuously and positive growth flagged, then subculture done on blood agar and Mekongki agar. Enrichment broth, selenite F broth, tetrathionate broth, and gram-negative broth are used. Selective media, low selective Mekongki agar, which gives the colorless colonies. Highly selective media, DCA, deoxycholate citrate agar, pale colonies with black center. XLD agar, xylose lysine deoxycholate, red colonies with black center. SS agar, Shigella salmonella agar, colorless with black center. Hecton enteric agar, blue-green colonies with black center. Wilson Blair brilliant green bismuth sulfite medium, jet black colored colonies with metallic sheen due to production of H2S. Identification, S. typhi, culture smear and motility, gram-negative, non-sporing, non-capsulated, motile with peritracheate flagella. Biochemical identification, catalase positive, oxidase indole negative, MR positive, citrate urease negative. TSI, K by A, alkaline by acid, gas absent, H2S, S. typhi, spake of H2S. In paratyphi A, citrate negative, H2S absent, gas present. In paratyphy B, citrate positive, abundant H2S and gas present. Slide agglutination test. S. typhi agglutinates with O9 antisera. S. paratyphy A with O2 antisera. S. paratyphy B with O4 antisera. Masking effect of VI antigen tested with VI antisera, boiled for 60 minutes at 100 degrees Celsius, testing with O antisera. Demonstration of serum antibodies in second week. Vidal test. Principal tube agglutination test. O and H antibodies against S. typhi and paratyphi AB are detected. Antigens used for, that is antigen of S. typhi TO, H antigen of S. typhi TH, H antigen of S. paratyphi A AH, and H antigen of S. paratyphi B BH. Procedure. Patient serum is serially diluted in normal saline in test tubes from 1 to 10, 1 in 640 dilution. 4 such sets are made. To each set of diluted sera, respective 4 antigens, that is TO, TH, AH, BH, are added. Control tubes containing antigen and normal saline should be kept to check for auto-agglutination. Test tubes are incubated in water bath at 37 degrees overnight. Result: O-agglutination, compact granular chalky clumps, disc-like pattern with clear supernatant fluid. H-agglutination, loose fluffy cotton leaf clumps with clear supernatant fluid. No agglutination, button formation, and supernatant fluid remains hazy. Titer: highest dilution of sera at which agglutination occurs. Significant titer in India: H-agglutinin more than 200, O-agglutinin titer more than 100. Low titer should be ignored and considered as baseline titer in endemic area. O antibodies are serotypes, non-specific. H antibodies are the specific. Interpretation of Vidal test. Rise of TO and TH antibody, enteric fever, S. typhi. Rise of TO and AH antibody, enteric fever due to paratyphi A. Rise of TO and VH antibody, enteric fever due to S. paratyphi B. Rise of only TO antibody, recent infection. Rise of only TH antibody, convalescent or anamnestic response. Rise of all TH, AH, BH antibody, post-TAP vaccination. False positive Vidal test may occur in anamnestic response, transient rise of titer due to unrelated infection like malaria, dengue in persons who have had prior enteric fever. Antigen suspension are not free from fimri. Persons with inapparent infection, person with prior immunization with TAP vaccine. False four-fold rise in antigen titer demonstrated by testing paired sera at 1 week interval is more meaningful. False negative early stage first week of illness, late stage after 4 weeks. Carriers, patients on antibiotics, prozone phenomenon, antibody excess. This can be obviated by serial dilution of sera. O-agglutinins appear early and disappear early and indicate recent infection. H-agglutinin appear late and disappear late, and they indicate convalescent infection. Other antibody detection test, Typhi.omp, outer membrane protein antigen is used, detect both IgM and IgG antibodies. IgM dipstick test and ELISA detects anti-LPS IgM antibodies. Dot blot assay, flagellar antigen is used and detect only IgG antibodies. Demonstration of salmonella antigen in blood and urine by ELISA. Molecular methods, PCR, detect and differentiate typhoidal salmonella, flagellin gene and other genes. Other non-specific methods, WBC count, neutropenia with leukocytosis, liver function test deranged, and the muscle enzyme level moderately elevated. Typhoid carriers, types fecal carrier, multiply in gallbladder and excreted in feces, more common. Urinary carriers multiply in kidneys and excreted in urine. According to duration of shedding, convalescent carrier 3 weeks to 3 months, temporary carrier 3 months to 1 year, and chronic carrier more than 1 year. Chronic carriers 1 to 4% of infected people, more common in women, infants and old age. Biliary tract abnormalities which lead to increased fecal excretion. Abnormalities of urinary tract and associated cystosoma hematogame infection of bladder leads to increased urinary excretion. Food handlers or cooks who become chronic carriers, dangerous. Example, Mary Mellon, typhoid Mary, more than 1300 cases are infected from her. Lab diagnosis of carriers, culture, stool and bile culture detects fecal carrier and urine culture detects urinary carriers. Detection of VI antibodies. Tube agglutination test using VI is typhi suspension carrying VI antigen but Nagar strain. Titer of 1 to 10 is also considered significant. Isolation of Salmonella from sewage to trace the carriers in the communities. Sewer swab technique and filtration, that is indirect way of the diagnosis. Control of carriers, early detection of carriers by stool urine culture or by detection of VI antibodies, effective treatment of carrier by ampicillin or amoxicillin 4 to 6 gram per day plus probenecid 2 gram per day for 6 weeks, surgery cholecystectomy plus ampicillin. Prophylaxis, control of reservoir, control of cases, early diagnosis and prompt effective treatment, disinfection of stool or urine soiled clothes with 5% cresol, 2% chlorine or by steam sterilizer. Follow-up examination of stool and urine culture to detect carrier twice at 3 to 4 months and at 12 months. Sanitation measures, protection and purification of drinking water supplies, hand washing and improvement of basic sanitation, promotion of food hygiene and health education. Vaccine provides short-time protection. Indications: travelers going to endemic areas, those attending melas and yatras, household contacts, and people at increased risk, school children. First, parenteral VI polysaccharide vaccine. It is capsular polysaccharide derived from S. typhi strain TY2. Single dose intramuscular or subcutaneous, protection for 2 years, booster every 2 years, and age more than 2 years. VIREPA, VI antigen is conjugated with recombinant Pseudomonas aeruginosa exotoxin A, can be given to less than 2 year children. Typhoral, oral live attenuated S. typhi TY2 1A vaccine. Stable live attenuated mutant of S. typhi strain TY2 1A. Gal E mutant, so it lacks the enzyme UDP galactose 4 epimerase. Multiplies for some time, initiates immune response and self-destruction after 4 to 5 division. Indicated only after 6 years of age. Enteric-coated capsules before food on alternate days, that is 1357, with booster 5 after every 5 years. Protect immunity starts after 7 days and lasts up to 4 years. Salmonella, morphology, gram-negative rods, motility positive, forming motility by peritracheate flagella. Classification: Salmonella typhi, paratyphi A, paratyphi B, paratyphi C. Pathogenicity: enteric fever, typhoid fever with a Salmonella typhi, paratyphoid fever, Salmonella paratyphi ABC. Septicemia, gastroenteritis or food poisoning. Fever, step ladder pattern, remittent fever. Other symptoms: headache, chills, cough, sweating, myalgia, arthralgia. Rash, rose spots, faint salmon-colored blanching, maculopapular rash over trunk and chest. Other intestinal manifestation and important signs: hepatosplenomegaly, epistaxis, bradycardia, complication, GI bleed, intestinal perforation, and neurologic. Lab diagnosis, type of specimen depend on duration. First week, blood, bone marrow culture, and duodenal aspirate. Second, third week, serum for Vidal test and urine and stool culture. Carrier, stool and urine culture. Serum for detection of antibodies to VI antigen sewage culture indirect way. Colonies of S. typhi, conventional BHI growth, automated back or back T alert. Backtick or back T alert. Subculture on Mekong-ki agar, blood agar. On Mekong-ki agar, non-lactose fermenting colonies, BCA, pale colonies with black center, XLD agar, red colonies with black center, Wilson Blair, black colonies. Identification: conventional culture smear, gram-negative bacilli, motility positive. Biochemicals: catalase positive, oxidase negative, indole, citrate urease negative, MR positive, and TSI shows K by A gas present except in S. typhi, H2S, S. typhi, small specks, and paratyphi A absent, paratyphi B abundant. Automated by multitop or Vitek. Antibody detection 2 to 3 week of illness, Vidal test. Either by slide or tube agglutination, and result O antibodies, granular chalky clumps, H antibodies, cottony woolly clumps. Significant titer O more than 100, H more than 200. So let's study in detail Shigella. Dysentery is characterized by diarrhea with increased blood and mucus.
and associated with the symptoms like fever, abdominal pain, and tenesmus. So what is tenesmus? It is feeling of constant need to pass stools despite of the empty colon. So now we will see organisms causing dysentery. So there are two types of dysentery: bacillary dysentery caused by bacteria and parasitic dysentery caused by the parasites, and more common in that is the amoebic dysentery. So the organisms causing bacillary dysentery are Shigella species, Campylobacter jejuni, enterohemorrhagic E. coli, enteroinvasive E. coli, and Vibrio parahemolyticus. And parasites are Entaminma histolytica, Balantidium coli, Trichuris trichuria, Cystosoma mansoni, and Cystosoma japonicum. So let's see first the difference between amoebic and bacillary dysentery. So on gross or macroscopic examination, the frequency of stool in amoebic dysentery is 6 to 8 times per day. In bacillary, it is more than 10 times. Amounts in amoebic dysentery is more relatively copious. In bacillary dysentery, stool amount is small. Odor in amoebic dysentery is offensive. In bacillary dysentery, it is odorless. Color in amoebic dysentery is dark red, bacillary it is bright red. Nature of the stool in amoebic dysentery is blood and mucus mixed with the feces. In bacillary dysentery, mainly it is blood and mucus and scanty or no feces. Reaction in amoebic dysentery, pH is acidic, and in bacillary it is alkaline. Microscopic examination, RBCs are present in clumps in amoebic dysentery, and in bacillary they are discrete. In amoebic dysentery, pus cells are scanty. In bacillary dysentery, pus cells are many. Then eosinophils present many in amoebic dysentery, and there are very few in bacillary dysentery. Parasites, tropozoites of Entaminma histolytica can be seen in microscopic examination of saline and iodine wet mouth, and parasites are nil in bacillary dysentery. Charcot Leyden crystals, they are present in amoebic dysentery and they are absent in bacillary dysentery. The Shigella is the most important causative organism of the bacillary dysentery. In 1896, Japanese microbiologist Kiyoshi Shiga isolated first member, that is Shigella dysentery serotype 1 from epidemic dysentery. So because of the Shiga scientist, the name given to the bacilli, that is Shigella. The classification is based on the biochemical and serological characteristics. They are divided into four species. So, based on mannitol fermentation, mannitol fermentation negative are called as Shigella dysentery, and the reaction showing positive, they are of three types: Shigella flexneri, Shigella voidi, and Shigella sonnei. And second classification based on somatic O polysaccharide antigen. They are divided into four groups A, B, C, D. And A is Shigella dysentery, B is Shigella flexneri, C is Shigella voidi, and D is Shigella sonnei. Antigens and serotyping of Shigella. So first Shigella dysentery, that is group A, it has 15 serotypes. It does not ferment mannitol and it is catalase negative. And the type 1, it is also called as S. shigi. It is the only Shigella species to produce Shiga toxin. Shigella flexneri, that is group B, it has 6 serotypes. Shigella boydi, that is group C, it has 19 serotypes and it is described by void, so the name given voidi to this species. And it is least frequently isolated from the cases of the bacillary dysentery. Shigella sonnei, that is group D, it has only one serotype. The other antigens may be present, that is K antigen, and if it is present in some serotypes, it covers O antigen and makes it inagglutinable by homologous O antisera. And sometimes fibrillar antigens are found, but flagellar H antigen is absent. And Shigella, other than Shigella sonnei, cross react with the E. coli. So now let's study morphology. So Shigella bacilli are short rods and they are gram negative, that is pink in color in gram staining. They are non-motile in hanging drop preparation. They are non-sporing, non-capsulated, and fungria may be present. Cultural characteristics, they are aerobes and facultative anaerobes. The optimum temperature for growth is 37 degrees Celsius and pH is 7.4. They grow on ordinary media and the colonies are 2 mm in diameter, circular, convex, smooth and translucent. For the enrichment broth, the selenite egg broth, tetrathionate broth, gram negative broth, can be used for the enrichment of this bacteria, and they show uniform turbidity in 24 hours, and then it can be subculture on the selective media. The selective media for Shigella species, they are divided into two categories: mildly selective and highly selective. So mildly selective are mainly most commonly used McConkey agar, which gives non-lactose fermenting, that is pale color colonies on the McConkey agar, and highly selective medium, that is DCA, deoxycholate citrate agar, then XLD, xylose lysine deoxycholate agar. So it gives red color colonies without black center. So here it is important to know the black center, because Salmonella species also show red color colonies but with black center because of the H2S production, and Shigella does not produce H2S, so it shows only red colonies without black center. Then SS agar, that is Salmonella shigella agar, and Hecton enteric agar shows green color colonies. So these are the selective media for the Shigella species. Identification and confirmation of the Shigella species is done by biochemical reactions. So catalase is negative in Shigella dysentery, and then it is positive in rest of the three, that is flexneri, boydii and sonai. Indol, the Shigella species gives indol reaction variable. Methyl red positive in all the species, citrate urease negative in all the species, lactose sucrose not fermented in all the species except in sonai. The Shigella sonai is late lactose fermented on the further incubation. It gives pale pink color colonies. Glucose fermented in all the species, mannitol not fermented in Shigella dysentery, and in rest of the three, flexneri, boydii and sonai, it is fermented. The triple sugar ion pattern is K by A, that is alkaline, slant and acidic, but because only glucose is fermented and the lactose and sucrose in this triple sugar is not fermented, so it gives K by A pattern. Here you can see these positive negative controls given to see the to study reactions, that is indol, MR, citrate, TSI and urease. So in indol it is purple ring positive, then methyl red positive is red in color, citrates blue in color, urease pink in color, and TSI is alkaline pink in color, and slant, if it is acidic, it is yellow in color. Now let's study virulence factor which makes the organism pathogenic. So first is the toxin. In that, endotoxin, which is lipopolysaccharide portion of the gram-negative bacilli, it has irritating action on intestinal wall leading to diarrhea and then later ulcers. The exotoxin produced by Shigella species is Shigatoxin. It is produced mainly by Shigella dysentery type 1 species, and the mechanism is it inhibits protein synthesis by inhibiting 60S ribosome. So it has two parts, A and B. B is mainly for the binding and A is for the action or activity, and then it inhibits the protein synthesis by inhibiting 60S ribosome. The toxic activities are mainly three types, that is enterotoxicity, neurotoxicity and cytotoxicity. The enterotoxicity of Shiga toxin, it acts on the intestinal mucosa and which causes accumulation of fluids in the lumen, and then it causes diarrhea. It has two types, that is Shigella 1, toxin 1, Shigella enterotoxin 1 and Shigella enterotoxin 2. So one is structurally similar to cholera toxin and it is found in Shigella flexneri 2A. Shigella enterotoxin 2 is present in all the Shigella flexneri isolates and it helps in ion uptake. The neurotoxicity, in that it damages endothelial cells of the small blood vessels of the CNS and resulting into the neurological complications like coma, paralysis. Cytotoxicity, this action is similar to virocytotoxin of enterohemorrhagic E. coli. Shigella is the most important cause of the bacillary dysentery. So mode of transmission in Shigella species is ingestion. So contaminated fingers or food or water and sometimes flies cause the infection. Then spread is by carrier or cases by fecal-oral route. It is unaffected by gastric acid or bile and therefore it reaches large intestine and then it causes the disease. The minimum infective dose of this bacteria is 10 to 100 bacilli and they are enough to cause the infection. These bacteria, they are not commensal of the intestinal flora and because of that the minimum infective dose is 10 to 100 bacilli. Pathogenesis of Shigella species is by entry through the M cells in the mucosa. So they are engulfed by macrophages. In the macrophages they multiply and then they are released. Then there is a recruitment of inflammatory cells to the infected site and which causes acute colitis. The invasion is the main factor for the causing of the bacillary dysentery. So once inside the submucosa, Shigella induce their own uptake into the adjacent epithelial cells and they spread direct cell to cell by inducing actin polymerization of the host cells. The bacteria adhere to the underlying epithelial cell and get ingested by these cells. And they multiply and spread laterally and deep into the lamina propria. They develop inflammatory reactions with capillary thrombosis, then sloughing, and then ultimately ulcer formations. The exotoxin causes accumulation of fluids in the lumen and which causes watery diarrhea. And then after that, because of the ulceration, there is bleeding and then it causes stool mixed with the blood and mucus and that is called as the dysentery. Here is the summary of these virulence factors for the Shigella bacillary dysentery. There are two mainly, invasion and toxin. So invasion through M cells, Shigella invades cells from basolateral sites by polymerization of actin fibers, and then toxin, there are two, endotoxin and exotoxin. Exotoxin is Shiga toxin and it inhibits the protein synthesis by acting on 60S chromosomes and ultimately cell death and then the ulcer formation is there. So in this diagram you can see the bacteria Shigella, they invade through M cells, then macropinocytosis, then in the macrophages they multiply, then there is polymerization of the actin filaments and then there is secretion of the toxins and then ultimately inflammation, necrosis and then ulcer formation. So clinical manifestation of bacillary dysentery. So it is incubation period 1 to 4 days, that is short period, and then initially you will see watery diarrhea with fever, malaise, anorexia and vomiting. Then there is frequent passage of bloody mucopurulent stools with increased tenesmus, that is filling of incomplete emptying of the feces and abdominal cramps. On endoscopy, you can see edematous and hemorrhagic mucosa with ulcerations and overlying exudate. Mostly this disease is self-limiting. Then complications may be there in children less than 5 years. So intestinal complications like toxic megacolon, perforation and rectal prolapse will be there. In metabolic complications, hypoglycemia, hyponatremia and dehydration because of the watery diarrhea. Then Ikiri syndrome or toxic encephalopathy with altered consciousness, seizures, delirium and abnormal posturing and cerebral edema is there. Sometimes you can see bacteremia leading to meningitis and pneumonia. In post-infectious phase, HLA-B27 gives autoimmune reaction after the months after the shigellosis. In that you can see reactive arthritis, ocular inflammation and urethritis. It is seen only after Shigella flexneri infection, mostly in 3% of the cases. Now let's study epidemiology of the Shigella bacteria. So risk factors are mainly overcrowding, poor hygiene and children less than 5-year-old. So epidemics can be seen in developing countries. Shigella flexneri is giving a 60% infection in the developing areas including India and Shigella sonnei 77% infections in developed and industrialized world. Shigella dysentery type 1 shows high mortality, epidemics of dysentery and particularly in refugee camps. Now let's study laboratory diagnosis of bacillary dysentery. So first is the specimen collection. So in that fresh stool sample is more preferred than the rectal swabs because rectal swabs not giving satisfactory results. And if there is delay in the examination, then transport media like sacs, buffer glycerine, saline can be used. Then first step after the specimen collection is direct microscopy. In that first wet mount of the stool sample can be done in saline preparation. Then here you can see large number of pus cells because of the mucus production and then erythrocytes and macrophages. Then we can do isolation of the bacteria. So first is the enrichment broth that is selenite F broth, tetrathionate broth or gram-negative broth. In that, bacteria gives uniform turbidity in 24 hours. Then subculture can be done on selective media. So selective media, most commonly used selective media for the Shigella is Mekongii agar. So selective media is used because Shigella bacteria is not a commensal, and then other commensal bacteria should not grow. So that is why we should use selective media, and most commonly used media is Mekongii agar. In that, bacteria gives you pale color colonies, that is they are non-lactose fermenting colonies. Then highly selective media can be used for the Shigella bacteria isolation, that is DCA, deoxycholate citrate agar. In that we can see translucent colonies. Then XLD, that is xylose lysine deoxycholate agar. In that, Shigella bacteria gives red color colonies without black center. So as I already mentioned, so black center with red color colonies is seen in Salmonella. So this is to differentiate it from the Salmonella. Then SS agar is used, enteric agar is used. In that, Shigella gives green color colonies. Then after the colonies identification, we can do culture smear and motility testing by hanging drop method. So in that we can see gram-negative bacilli. They are short rods, non-motile, non-capsulated and non-sporing. Further identification of the Shigella species is done by biochemical reactions. So in that, catalase is positive in all the Shigella species except Shigella dysentery type 1 and Shigella flexneri serotype 4A. Indole production in Shigella species is variable. Methyl red is positive, oxidase citrate urease negative, TSI gives K by A, that is slant alkaline, and yellow color but that is acidic in reaction with no gas and no H2S. Mannitol fermentation in all the species except Shigella dysentery and Newcastle biotype of Shigella flexneri serotype 6. Lactose sucrose are not fermented except Shigella sonnei, which is late lactose fermenter. Gas production all are anaerogenic except Manchester and Newcastle biotypes of Shigella flexneri type 6. Slide agglutination test is done for confirmation using group specific and species specific antisera, and bacteriocin and colicin typing is done for Shigella sonnei. And then after that we can do antimicrobial drug susceptibility testing. So here you can see this summary of the lab diagnosis. So first is gross examination of the stool sample, then microscopic examination by wet mount. In that we can see pus cells and RBCs. Then isolation of the bacteria is done on Mekongii agar, DCA, XLD agar. Then final confirmation of the bacteria by biochemical testing, and then antibiotic sensitivity like antibiotics like ampicillin, ciprofloxacin, nalidixic acid, norfloxacin, tetracycline can be used for the testing. And then agglutination test can be done by using polyvalent and monovalent antisera. The Shigella dysentery is a self-limiting disease, so each patient should not be treated with antibiotics. The drug of choice for the infection is ciprofloxacin, and other drugs can be ceftriaxone, azithromycin, and some fifth generation quinolones. The treatment should be given for 3 days, and for Shigella dysentery type 1 should be continued to 5 days, and in immunocompromised patients it should be continued to 7 to 10 days. And oral rehydration ORS should be started as soon as possible after the initial rehydration. Prevention of this bacterial dysentery can be by strict infection control measures of contact precaution. Hand washing should be done after the handling of children's feces and before handling food. Stool decontamination can be done with sodium hypochlorite. And as of now, no vaccine is available for this disease. So these preventive measures should be done for prevention of the disease. To summarize, dysentery is the diarrhea with blood and mucus and scanty stool is there. The most common organism for bacillary dysentery is Shigella species. It has 4 groups A, B, C, D, that is Shigella dysentery, then Flexneri, Boydii and Sonnei. And morphologically, Shigella is gram-negative bacilli, non-motile, non-sporing and non-capsulated. On cultural characteristics, most common selective culture media used is McConkey agar. Routinely, it is showing non-lactose fermenting, that is pale color colonies. And then pathogenesis of this disease is by invasion and toxin production, that is Shiga toxin, which gives you three toxicities, that is enterotoxicity, neurotoxicity, and cytotoxicity. Clinically, this bacillary dysentery showing short incubation period, then initially diarrhea, watery diarrhea is there, and then it is associated with the blood and mucus, that is dysentery, and it is a self-limiting disease, but sometimes you may get complications, that is the megacolon or interception or other complications. In the lab diagnosis, that is isolation of the bacteria is done on McConkey agar, and then selective media other can be used like DCA or XLD. And then on McConkey agar you can see pale color colonies, that is non-lactose fermenting, and in DCA agar you can see red color colonies without black center, that is differentiating point from the Salmonella, which is showing black center because of the H2S production. And biochemical tests can be giving identification. So mostly they are catalase positive except the Shigella dysentery type 1. Indole reaction is variable, methyl red reaction is positive, citrate, urease, oxidase they are negative, and TSI pattern is K by A, that is alkaline slant, and acidic, that is yellow color. But and mannitol fermentation is there except the Shigella dysentery, and lactose sucrose are not fermented except the Shigella sonnei, which is less lactose fermented. So on further incubation, you can see on McConkey agar pale pink color colonies of the Shigella sonnei. And then ciprofloxacin is the drug of choice, and prevention is mainly hand washing and maintaining hand hygiene. So the take-home points can be shigellosis is common in children of the tropical countries like India. Shigella are non-motile, non-lactose fermenters, non-H2S producers. Disease is a self-limiting, treated by fluid replacement, and often do not require antibiotics.
Shigella morphology gram-negative bacilli, non-motile, non-sporing, non-capsulated. Classification based on mannitol fermentation: positive Shigella flexneri, Shigella voidi, Shigella sonnei, and mannitol fermentation negative Shigella dysentery. Shigella dysentery pathogenicity: bacillary dysentery, passage of loose scanty feces with blood and mucus, gripping pain, fever, vomiting plus minus, plenty of pus cells on stool microscopy. Phase of complication: children less than 5 years, intestinal complications, toxic megacolon, perforation, rectal prolapse, metabolic complications, hypoglycemia, hyponatremia, and dehydration. Lab diagnosis: specimen, fresh stool, rectal swabs are not satisfactory. Transport media: sacs, buffered glycerol saline. Wet mount, large number of pus cells and erythrocytes. Culture: enrichment broth, selenite F broth, tetrathionate broth, gram-negative broth. Selective media: mild, McConkey agar, non-lactose fermenting colonies. LLF pink, late lactose fermenting colonies in Shigella sonnei. Highly selective medium, DCA and XLD agar. Culture smear motility: gram staining, gram negative bacilli, non-motile. Identification: conventional or automated. Automated by systems such as Maldi-Toff or Vitek. Conventional catalase positive except Shigella dysentery, serotype 1. Oxidase negative, indole negative, citrate negative, urease negative, TSI triple sugar ion sugar taste, K by A. Alkaline by acid, gas absent, H2S absent.
Hope you find this session useful for your understanding and for your exams. Thank you.